going to, we do have a lot of speakers for this panel, and we're going to have a question and answer session once they've all had a chance to present for you. I just want to comment on one thing. He mentioned it, think about the concept that he mentioned of an orphan drug. That means it corresponds to a disease that kills people or makes their lives miserable, that private companies don't want to spend the money to develop a treatment for it. And I've had some personal experience with that kind of disease. And he also mentioned the fact that these pharmaceutical companies aren't spending the money on infectious diseases. I guess it's because there's no profit in it, or that most of the people that die from it don't have the money to make it profitable. Well, this is insane. It's like evacuating California because there's not enough water instead of getting the water to the people, as Rachel mentioned. So, Obamacare is not helping, but I would say that it just reemphasizes the fact that we need an international commitment and coordinated effort to deal with these health crises. And it's important that we reinstitute the American system of political economy in order to finance this. And that involves restoring Glass-Steagall and reestablishing a credit system in the United States. And fortunately, the American system is alive and well in the BRICS countries. The principle of state credit is being utilized by China and India to take care of these problems. And we've got to reinstitute it here. That's part of what it means for the United States to be part of BRICS. But I want to applaud George for keeping the pilot light on while all of that dried up, to help, make sure that there were some efforts being done by hook or by crook. So thanks, George. All right. Our next speaker is Saket Mishra, who is an inventor, an entrepreneur, and he's here from the Association for India's Development at the Massachusetts Institute of Technology. He's going to talk about the application of technology to solve some of these problems, including diabetes, I believe.
Yeah, I was just hoping for that kind of a lead, diabetes. So these are the three organizations that I'm representing. Hi, I'm Saket Mishra here. The first one is Association for India's Development. The second one is Atlas Core, which is a fellowship program for social nonprofit leaders across the world to serve in US in various nonprofits and beyond profit organizations for 2 years. And the third one is Mass General Hospital, where I'm serving currently as part of the fellowship. So when I actually came here almost a year and a half back as part of the fellowship program, I knew the problems that my country had, India had, but I did not necessarily think that I would be able to solve them in that short span of a time. But the problem that I was very truly drawn towards was healthcare as a whole. And I spent the next 1.5 years trying to find solutions, at least I was hoping, around that problem. So if you could go to the next slide. So this is the overall picture of healthcare. I mean, it may look grim, but I promise we'll be towards a much more hopeful place. So if you see, the problems of healthcare, when I was coming from India, I did not necessarily think the healthcare system was any different in India than it was in America, because we had around 0.7 doctors for 1,000 people. Whereas in US, there are 2.5 doctors for 1,000 people. 100 million diabetics, so we are actually the diabetes capital in the world, whereas there are just 20 million people in US. the paying power of individual people is less than 5% population is around on insurance, which is not completely covered. So everyone is really paying out of their pocket. So here, if you say the typical system is people in emergency go to the emergency ward and someone's paying for it, either the system is paying for it or the insurance company is paying for it, or us as subdivided systems are paying for that person's visit. So that's not how that system, there is absolutely no healthcare system existing in India. It is like a sector that exists right now. So because of this whole spending that people have to do from out of their pocket, 30 to 35% households every year went below poverty because of this catastrophic spending. So I said, what is the commonality that I can draw? Because people at Mass General Hospital would be interested in products that are relevant for US. But can I actually, in that work, also find some meaning in the products that I can take back home? Once I go and want to work in some organization which is working for India's development. And I kind of did. So if you go to the next slide. So the opportunity that I saw when I came here, this organization, Center for Connected Health at Mass General Hospital, was a technology, it was a research lab that was doing work for chronic management, disease management, and patient-centered care, which is a complete new concept of disease management. And the things that we have in common between India and US, this place is really talking about the Silk Route. And I think one thing that I really saw common between both of them were both these countries are heavy technology users. If you realize from Ranjani's talk, she actually mentioned that most of them are mobile. Actually, 95% of our population is on some form of mobile connectivity, which you would imagine such a poor developing nation, but actually no. The innate need to be connected to each other is so grave that people are actually on technology. By 2020, just to give you an estimate, India would surpass the number of internet users that US has. So that is the number, the need and the technology that we are looking at. India is going to be connected in a complete new way. I said, can this really be the common ground between the innovations that we come up with and may not be necessarily medicine-based or pharma-based? Could the solution be completely different? And we did. So I'll talk about the first product, which is about diabetes, thankfully. Could you go to the second? So in order to revolutionize the healthcare system itself, I talked about these three questions to myself a year and a half back, and I said, can technology take manual intensive tasks away from the health system so that it improves the access? So for example, if you come to the doctor and say, I have diabetes, or the doctor says, oh, you have diabetes or some other disease, and now you go back home, take this medication, you manage your own health. But then I'm not really meeting the doctor till my blood sugar shoots up, or there's kidney failure, or any of those things. But I still am managing my disease. So can I actually improve that innovation, that access itself for the patients so that they can manage their disease, and then only for the acute care is when we need the hospitals or the physical one-on-one time with the doctors. The other answer that the question that I was talking about is, can we also design tools, because India does not have the kind of data gathering healthcare system, epic kind of a system where you are protecting the data. We don't have any data system, so we don't even protect it. But can we actually design a tool around it? So we did. I'll talk about the first intervention that we did. The first intervention was called Text to Move. There were three, I'll explain the intervention. There were a group of people, half of them were the control group, the other one were an intervention group. The intervention group were basically given a Fitbit meter, which is a pedometer. I hope most people know about it, the one that measures your step counts. The other data that we were collecting were their personal data that we were collecting. And the third one was their medical data from their medical records. And we realized, could we go to the next one? So we actually saw HbA1c is the gold standard for blood glucose control. And we actually saw that people without medication, mind you, without medication actually received 0.62 levels of HbA1c management. You'd be surprised that with the gold standard medication, which is metformin to manage diabetes, people achieve only 0.5. We actually did much better than the medications. And this is just by engaging, personalizing, and customizing their daily step counts. That's all that we did for these diabetes patients. Now, if you see, there are two groups. One is a high engagement group, which also saw a tremendous HbA1c control, and the other low engagement group as well. What we did is, imagine we all are working wearing this pedometer, and imagine a diabetic walks less on a certain day, and we collect all of that data, and then we correlate to all the machine learning that we did. And we realize that, say, Saket, you walk less when it is rainy or snow outside. You don't necessarily step out. Even in your house, you walk less. So tomorrow is going to snow. Do you want to walk a little more today? We actually personalized and customized the entire data because it was an aggregate of the step counts that you were about to reach. And we had much better blood sugar control. And this is what technology can do. This is what I really came here for. This is what innovation of looking at the problem differently can do. Can you go to the next slide? So the second problem that I really was very close to is I wanted to talk about the really marginalized, closeted population. Imagine mental health. In US, it's really, really common for people to take therapy and go to psychiatrists. But mental health across the BRIC countries is a big issue because there's a huge cultural, social taboo around mental health. And for every 4,000 people, there is one psychiatrist in India. That's the data I have. So we don't really have access, and these are really focused in the urban area. So in the rural, the villages, B-towns, probably this is non-existent for a large number of population. What it basically does is 30% people go underdiagnosed or never diagnosed for depression or anxiety or any of these medical conditions. And that in effect affects their adherence, their disease control, their outcomes, their chemotherapy, everything that you can imagine. I said, can we actually dehumanize this process? Because it is really about a therapy. Can we dehumanize the process where cultural barriers go away, language barriers go away, the interaction and the speed of learning is given to the user or the consumer or the patients, and not necessarily I'm constantly thinking about the money I'm spending to go to the hospital or go to the system or the taboo of going to the ward that looks like a mental ward in a country. So we designed this system. So we designed this system with the help of Department of Psychiatry and MGH, where an iPad, or it actually works on the cheapest of available tablets and Android tablets, which are around 2,000, 3,000 rupees, which is less than $70 or $60. So it works even on that system. It ranges amongst the system. So this is a non-distractive, fatigue-friendly design. What we did is you can go at your own pace. This person, the psychologist who's trained, will be giving you the cognitive behavioral therapy. This particular intervention was done for end-of-life cancer patient care, where even in the city, in the entire area of Greater Boston area, there are only 2 psychiatrists who are even equipped to do this kind of a therapy. And by the time the name of these cancer patients really come in the roster, they're no more there. So, and this affects their outcomes, their life, their quality of life, anxiety, depression, everything all together. So we designed this system where these patients could interact at every 3 or 4 minutes. So they can go at their own pace. We could even collect the data if they're understanding the concepts very well. There were hundreds of homework modules and interaction modules, which help the people to understand the concepts from a very dehuman, personal, in-home kind of a care. Could we go next? So these are some of the screenshots, if you see. The app actually helped people walk through the homework. The patient felt empowered because they could answer the questions that probably were missed. And if they wanted to go back and see the same process again, which not necessarily you get in the luxury that you get in a therapy. And they could do all of this care. And this is what we designed for the department. So at the end, I want to leave you with one thought, that you would imagine various people, like we talked about, the frugal innovation and all of those things coming from, and jugaad coming from different countries, you would be surprised that the people who actually approached finally after a year and a half of publishing this work and doing these kind of innovations around technology and healthcare, the people who approached us were not a healthcare system, were not government, was not a pharma company. You would think that those are the ones who would be the most interested in that. It was actually the #1 technology service provider from India that actually wants to create the first digital hospital in India. Imagine a hospital where people are managing their care at their homes, and you're only giving them care and service as a customer, or customer service within sitting in a hospital. It reduces the entire healthcare cost. The disease management itself is completely different. So that's all I did. What I did is I looked at the problem differently, and I did not think that I would be able to solve everything, but at least what I pick up, I would want to solve that completely. Thank you. And these are the 3 organizations that I'm representing. We have the websites. You can always access this. Thank you.